Hello, in this video I'll be talking about diabetes insipidus. The way I remember diabetes insipidus is that D for diabetes, D for deficiency of ADH. So you do not have enough ADH, which is antidiuretic hormone, to reabsorb water from urine. So this will lead to a dilute urine because all the water is staying in your urine. So the patient will present with polyuria, polydipsia and all of that, and you want to check the blood glucose levels first to see if this is not diabetes mellitus. If the blood glucose levels are fine, then you secondly you want to check the serum sodium levels. The normal serum sodium level is between 135 to 145. The way I remember this is that the normal pH is 7.35 to 7.45, and if you drop the 7 and make it a 1, it's 135 to 145 for normal serum sodium levels. So if the serum sodium levels are decreased, it means that the patient is drinking a lot of water, and that is causing the hyponatremia. So that would mean that this is a psychogenic polydipsia. If the serum sodium levels are elevated, this could be diabetes insipidus, but you still want to figure out whether this is a central diabetes insipidus in which there is not enough production of ADH. It can be due to tumors, trauma, etc. Or if it is a nephrogenic diabetes insipidus in which your kidneys are basically resistant to ADH. So no matter how much ADH you're going to give, it's not going to correct. So this could be due to lithium, and it could be congenital as well. So how would you differentiate these conditions? Is that you do a water deprivation test. You basically prevent the patient from drinking water, and in a normal patient the urine osmolarity should go up over time because there's not enough water, so the body will reabsorb water from urine, and this will increase the urine osmolarity. So your patient with psychogenic polydipsia is normal, right? So when you do a water deprivation test on a normal patient or a patient with psychogenic polydipsia, the urine osmolarity will go up over time. So maybe if the urine osmolarity was 200, over time it will go like 400, 600, 800 and so on and so forth. So it will increase over time. So this means that the patient was normal or has psychogenic polydipsia. But if the urine osmolarity goes up but not as much as it should, like say it was 200, then went to 220, 240, 260, it means that the patient has diabetes insipidus. The urine osmolarity is usually less than 300. So you still don't know whether it's central or nephrogenic. So you administer a ADH analog, which is desmopressin, and you see if the urine osmolarity increases. In central diabetes insipidus, you've basically corrected what was wrong by giving ADH, and so the urine osmolarity will increase like it should and probably go up to 500 to 800 milliosmoles per kg. In nephrogenic diabetes insipidus, the kidneys are still resistant to ADH, so desmopressin won't make a difference to this guy, and the urine osmolarity is going to stay less than 300. So a quick revision: first, you check the blood glucose levels. Second, you check the serum sodium levels. If it is decreased, it is psychogenic polydipsia. If it is increased, it means it is diabetes insipidus. Then you do a water deprivation test. If the urine osmolarity increases to about greater than 500 urine milliosmoles per kg, it is psychogenic polydipsia. And if it does not increase like it should, say the urine osmolarity says less than 300, then it is diabetes insipidus. After you give an ADH analog, if the urine osmolarity increases to say greater than 500 milliosmoles per liter per kg, it's central diabetes insipidus. And after giving ADH, if the urine osmolarity does not increase like it should, it is nephrogenic diabetes insipidus. So yeah, that is all. I hope that helped. Stay awesome. I haven't covered partial nephrogenic diabetes insipidus or partial polydipsia in this video. I think that's too complicated, but if you really want to know about it, in partial nephrogenic diabetes insipidus, the urine osmolarity is gonna after the water deprivation test, it's gonna be about 300 but less than 800. Less than 500. And after you give an ADH analog, it's gonna stay less than 800. So yeah.